Hello, everyone, and welcome to the HHQI Cardiovascular Learning Action Network, or what we call the Cardio Land, for September 2017. We'd like to thank all of you for taking the time out of your day to join us. Our hope is at the end of today's session, 1 hour from now, you'll be able to take some of the information that's shared and begin applying it in your clinical setting. Now, in addition to our guest expert, Hillary K. Wall, who we'll formally introduce you to shortly, we have Misty Kevich, who is an RN project coordinator for HHQI. And for those of you I haven't met, my name is Cindy Sun, and I'm the other HHQI RN project coordinator. Now, before we get started today, I'd like to mention that this event is being recorded, and it will be archived in the same area where you registered for this event and you found the slides. Now, for those of you that are still looking for the slides, they're available by going to the HHQI website at www.homehealthquality.org. And then hover your cursor over the Cardiovascular Health tab on the blue toolbar, then Cardio Land, and finally click on the word Webinar. All the lines are currently in listen-only mode. We may have to unmute the lines a little later, so for that reason, we'd like to encourage you to make sure that everything is muted on your end, because the last thing we want to do is listen in on any of your conversations. Now, we'll get to as many questions as time permits today, so we want to encourage you to use the Q&A feature on the right side of your screen to submit your questions. Now, if the Q&A or the chat feature are currently not showing on the right side of your screen, you can click on the icon in the upper right corner, and that will activate them. Now, for today's session, continuing education of 1.25 nursing CEs has been approved by the Alabama State Nurses Association, and they are an accreditor, an approved accreditor of the American Nurses Credentialing Center Commission on Accreditation, or the ANCC. In order to receive the CE credits, the participant must watch this webinar and then enroll in the corresponding course through HHQI University and complete the short evaluation, 15 minutes. Now, the step-by-step instructions will be covered at the end of today's webinar. Now, we have 4 announcements today because this is the Cardio Land, it's the Learning Action Network, so we'll go through these rather quickly, but we do want to keep you abreast of what else is going on. So the first announcement is about the changes to the Home Health Cardiovascular Data Registry. Starting in 2018, there will be changes to the registry. This will not impact patients that were discharged prior to January. So for those of you that are already entering data into the registry, it's not going to be that drastic of a change, but we do want to talk about it further in December, but just to let you know that that will impact March of 2018 will be the change. And like I said, we'll keep you fully abreast of that, but we always have slight changes, but this will be a little bit larger of a change. Now, speaking of the Home Health Cardiovascular Data Registry, or the HHDDR, we want to mention that the blood pressure control measure continues to be the most abstracted, and that's closely followed by the smoking cessation measure. Now, as a provider group, home health, most of you are continuing to demonstrate tremendous improvement in both of these measures, and there's lots of you that are demonstrating sustained improvement. So whether you are showing improvement or whether you're in the process of improving, or whether you are at the sustaining, we want to thank you for continuing to focus on this. We need to increase the improved quality of care that we want to give our patients. Now, because of the way the measures are designed, blood pressure has the most agencies abstracting, but smoking has the most patients. Because remember, the smoking cessation measure covers every patient that's discharged from your agency. Now, not too far behind those two is aspirin, and of course the cholesterol measure is the lowest, as it has been all along. But we're going to see if we can't make some changes to that. Now, the second announcement I wanted to mention is about the Immunization and Infection Prevention Best Practice Package. It was published a few weeks ago. Now, we all know in cardiovascular world the strong connection and how susceptible our cardiovascular patients are to these 2 diseases of pneumonia and influenza. We wanted to let you know that this document was released. It was curated, and it currently includes the most current CDC immunization guidelines, which were just released a few weeks ago. If you have downloaded an earlier version of the BPIP, we want to encourage you to replace it with this updated version. Now, the third announcement is about HHQI participation. We are thrilled in HHQI. We currently have 18,945 participants. That is 55 participants away from the 19,000 mark, and we're very excited about that. And we're representing 5,845 home health agencies in the country. So I know that many of you are from different provider settings or have nothing to do with home health. We want to let you know you're, of course, welcome. We want to encourage you to use the resources and continue down the path that you are, but it is still very exciting of this volume. Now, finally, the fourth announcement. The next HHQI webinar will be, as our third Thursday event, will be on October 19th, and it's for the underserved population, or the UP plan, with guest expert Deborah Sherry, Executive Vice President of Alzheimer's Greater Los Angeles, and she'll be presenting Creating Dementia-Capable Systems of Healthcare. The event's open to everyone, and you can register by going to the website, HHQI website, and clicking on the UP, or the UP link on the blue toolbar, and register for that event. Now that concludes the announcements. Let's get into today's objectives. Upon completion of this webinar, we hope that you're going to walk away from here and be able to describe the genesis of Million Hearts 2022. We hope that you're going to be able to identify at least 3 evidence-based tools and resources for hypertension control. We hope you're going to be able to describe the concept of finding potentially undiagnosed hypertensive patients, because you know and I know they're all out there. We've just got to find them. And identify 2 additional tools related to cardiovascular disease prevention. Now, for presenting our content today, the Million Hearts Toolbox for Hypertension Control and Beyond is Hillary K. Wall. Hillary K. Wall, MPH, is a senior health scientist for the Division of Heart Disease and Stroke Prevention at the Centers for Disease Control and Prevention, or the CDC. Hillary serves as the science lead for Million Hearts, an initiative from the Department of Health and Human Services, co-led by the CDC and the Centers for Medicare and Medicaid Services, with the goal of preventing 1 million heart attacks and strokes by 2022. In that role, she provides scientific expertise on topics including healthcare system change, clinical quality measurement, and health information technology. Hillary has 15 years of experience in cardiovascular disease prevention in both research and state and federal government. She holds a master's in public health degree in chronic disease epidemiology from Yale School of Public Health. Hillary, we'd like to thank you for taking the time to join us today. And with that, I will turn the webinar over to you. Thank you.
Great. Thanks so much, Cindy. I really appreciate being here with all of you, and I'm really delighted to talk to you today about Million Hearts and some of the clinical strategies we are supporting that we think will be most effective for preventing heart attacks and strokes through hypertension control and beyond. So I will start today. Let me make sure I can turn my slides. There we go. I'll start today with a quick overview of the burden of cardiovascular disease in the U.S. and a quick overview of Million Hearts. And I'll review a number of hypertension-related tools and resources that I think will be of interest to you, including some of the work, as Cindy mentioned, that we've been doing to highlight patients with potentially undiagnosed hypertension. And then lastly, I'll showcase additional tools and resources that can aid in broader cardiovascular health efforts. Again, trying to think about the kinds of tools and resources that might resonate with all of you. So every year in the United States, and you guys likely know these statistics backwards and forwards, but there's more than 800,000 adults who die from cardiovascular disease, and 1.5 million have a heart attack or stroke. Cardiovascular disease is the leading cause of potentially preventable death in the U.S., and as you know, the cost to our economy is huge. We see over $300 billion are spent every year in medical costs and lost productivity. So this is, as we all know, it's a huge issue. While we have seen a gradual decline in cardiovascular disease mortality over the last 40 years or so, it still remains the nation's leading cause of death for men and women of all races and ethnicities, and is responsible for about 1/3 of deaths worldwide. And alarmingly, in recent times, we've actually seen a deceleration of this rate of decline and even an acceleration in the rate of cardiovascular disease mortality in some subpopulations, which could indicate a reversing trend. And this is likely due to increases in obesity and diabetes, which probably aren't going away anytime soon. So if you look at this graph, in the 1970s or so, we see a steep rate of decline in mortality rate due to heart disease and stroke. When you look at 1980 to 2010, you see slower, though still constant rates of decline in those conditions. But then as we get towards the right-hand side, 2010 to 2015, you can see that the rate is flattening. And in some subpopulations, when we look at the data, we actually see a J-shaped curve. So that's what I mean by the rate is starting to accelerate again, and that's hugely problematic. So to really address this burden of cardiovascular disease, Million Hearts was launched, and it's this national initiative. As Cindy said, it aims to prevent 1 million heart attacks, strokes, and other acute cardiovascular events in the next 5 years. It's led by CDC and CMS, and that was really done intentionally to bring together public health and clinical medicine. But truthfully, it's carried out by a variety of partners at the local, state, and federal levels, and folks like you who are boots on the ground doing the most important work. That's what we rely on to try to achieve our goals. So what Million Hearts is, it really provides a platform to shine a light on a selection of evidence-based strategies for cardiovascular disease prevention, and it also serves as what we like to call a learning lab and a repository of tools and resources for partners to use to implement those evidence-based strategies. So to prevent 1 million heart attacks and strokes by 2022, we need to focus on 3 key priorities. First, keeping people healthy. And we do this by making changes to the environments in which people live, learn, and work to make it easier for people to make healthy choices, particularly through a 20% reduction in sodium intake, 20% reduction in tobacco use, and a 20% reduction in physical inactivity, if you will. Second, we're trying to optimize care so that those with and at risk for cardiovascular disease receive the services that they need to reduce the likelihood of having a heart attack or stroke. This includes achieving 80% performance on the ABCs, that is aspirin when appropriate, blood pressure control, cholesterol management, and smoking cessation. It also includes having 70% of eligible patients participate in cardiac rehabilitation and trying to improve patient engagement in their own personal cardiovascular health. And then our third priority area is improving outcomes for priority populations who suffer worse outcomes of cardiovascular disease and where there is evidence and the opportunity to make a significant impact. And so this was actually established as a new priority for this current phase of Million Hearts. We really wanted to focus strongly on a small set of priority populations. So let's dig a little bit deeper. To get to the goal of 20% reduction in sodium intake, smoking, and physical activity, we need to focus our collective efforts on sort of public health and public policy strategies. So strong evidence suggests, for example, that local food procurement policies can enhance consumer choice for lower sodium foods, while at the same time encouraging more producers to offer lower sodium alternatives. In the tobacco arena, smoke-free policies and pricing approaches are very effective in driving down tobacco use, so we'd like to spread the uptake of those approaches. And then we have promising evidence that increasing access to places for physical activity, designing communities and streets with physical activity in mind, as well as peer support type walking groups can help more people increase their physical activity level. And likewise, in order to achieve excellence in clinical care, we need to focus on effective healthcare strategies. And evidence has shown that high performers excel in the use of teams, including home health practitioners, pharmacists, nurses, community health workers, and cardiac rehab teams. Basically, we need everyone working at the top of their license and abilities. High performers also excel in the use of processes that ensure quality of care, such as treatment protocols, scorecards that show performance status on the ABCs, proactive outreach to patients about their risks, and finding patients with undiagnosed high blood pressure, high cholesterol, or tobacco use. Technology can also play a big role, things like electronic health records that include thoughtful clinical decision support, patient portals, bidirectional e-referrals, registries, and then algorithms to find gaps in care, all super important. And lastly, we're really interested in patient and family supports, things like self-measured blood pressure monitoring, medication adherence strategies, counseling on nutrition, physical activity, tobacco cessation, and avoiding exposure to particle pollution by monitoring the air quality index. We're also very interested in systematic referrals to community-based physical activity and cardiac rehab programs. So that's a big menu, but all of these things are found in systems, healthcare systems that excel in the ABCs. And I apologize, I have a cold, so I'm hoping I'm not going to start sneezing or coughing during the presentation. So there are many populations that have higher rates of cardiovascular disease that can stem from higher rates of risk factors, and this often leads to increased rates of death and disability in these populations. So Million Hearts, as I said before, we're calling attention to a few populations to consider focusing efforts on. These are Blacks and African Americans with hypertension, 35 to 64-year-olds, among whom those event rates I talked about earlier are on the rise. So kind of previously, hypertension and cardiovascular disease was really focused on in older adults, the elderly population, but we now understand we have to switch that attention and focus sort of on the spectrum of all adults. We also need to look at people who have had a heart attack or stroke. There's lots of opportunity for secondary prevention there. And lastly, focusing on tobacco use for people with mental illness and substance abuse disorders who use tobacco. Excuse me. And it's really important to note that these populations can obviously overlap, and this list is not exhaustive. So if there are partners who have a particular interest in a subpopulation where there's data to support the need to act and there are strategies that one could act upon, we're fully supportive of partners working in those areas. So I'll just move on. A foundational principle of Million Hearts for optimizing care is performance improvement or quality improvement. And early on in our work, we recognized the need to focus partners on a small, streamlined set of clinical quality measures for cardiovascular disease prevention. As you may know, there are just a dozen, if not more, quality reporting initiatives in this country. And back in like 2010, when we first started dabbling in Million Hearts, we realized there were dozens and dozens of cardiovascular-related clinical quality measures that a clinician could choose to focus on. And that really muddies the waters, and some of them were not as evidence-based as we would have liked. So we sort of picked a very small set, and we've worked hard to get those measures adopted into various programs. By picking that small, streamlined set, we acted to reduce the reporting burden on clinicians, which is, of course, super important, but we would also be focusing quality efforts to impact the same outcomes. So we're driving towards the same goals. We specifically chose measures that were evidence and guidelines-based, supported the goals of Million Hearts, and really best reflected population health outcomes. So rather than looking at very specific subpopulations of patients, we chose to look at more of a population health level. So you can see that the current set of Million Hearts clinical quality measures for the ABCs is on this slide, and there's some numbering nomenclature that hopefully you're somewhat familiar with. 3 of our 4 primary measures for aspirin, blood pressure, and smoking are included in the HHQI Home Health Cardiovascular Data Registry. I will tell you our cholesterol measure for statin use among high-risk patients, it's really a new measure that reflects very recent clinical guidelines, and we're actively working to get that adopted by quality reporting initiatives. So we don't have widespread adoption of that measure just yet, but we think that will happen in the next few years. But in particular, blood pressure control and smoking cessation measures have widespread adoption in over a dozen quality reporting initiatives, which we're very proud of. So behind these quality reporting initiatives, there's obviously data that then allows us to see where we're at as a nation on performance on the ABCs. So now that we have that ability, we now need the evidence-based tools and strategies to help us improve. So let's take a look at some tools for hypertension control. If you are not steeped in the world of quality improvement, you may not have heard the term change package. Well, a change package is a well-known quality improvement tool comprised of evidence and practice-based changes that support improvement in care processes. And it can include things like changes to assessments, referrals, medications, and other therapies, all things that the scientific literature and others have shown improve the outcomes of patients. And if you're doing quality improvement, you sort of hope that someone has put together a change package on the topic of interest. And for hypertension, Million Hearts has developed a change package that attempts to capture best practices in hypertension control to really help healthcare professionals and practices nationwide improve their patients' hypertension control rates. So you can access the full change package using the URL on this slide, but I will give you a quick peek at its different components. The change package is broken down into what we call change concepts, and these are sometimes referred to as key drivers. These are the broad areas throughout the continuum of, for example, a patient visit where changes can make an impact. Then there are change ideas, which are more specific, actionable suggestions for changing a process. And then for each change idea, we reached out to clinicians and quality improvement professionals in the field who were doing really well in hypertension control to try to gather tested tools that can help others make an impact in hypertension control. The change package itself is organized into 3 broad buckets. We have key foundations, population health management, and individual patient support. So let's take a look at an example from population health management to give you a better idea of what you'll find in the change package. And change concepts related to population health management are focused on things like using data and standardized approaches to drive improvement among a panel of patients by doing things like proactively monitoring and managing hypertension practice across the board. So it's really important it focuses on that panel of patients, not individual patients. So for population health management, maybe a healthcare setting decides it wants to use data to drive improvement. It turns out that the clinical staff at that healthcare setting don't think blood pressure control is a problem for the healthcare setting. So the QI team decides to use quantitative data from their electronic health record to highlight gaps in care. There are 2 aspects on which one can focus. 1, determining which metrics you should use to measure the quality of care delivered, or 2, regularly providing clinicians with dashboards or report cards. And the healthcare setting then decides it has a need for clinician-specific dashboards for care related to hypertension control. The change package then provides several examples like the ones you see on the slide that have been implemented by healthcare settings who achieved a high level of hypertension control. And these include a wide array of graphs, charts, tables, and spark lines from which one can choose and adapt to meet their needs. It's sort of a menu of data visualizations, if you will. So just back to the slide, this is how the whole change package is set up. You've got this change concept, you pick which of the several change ideas that are available for that change concept you want to focus on, and then we provide some tools and resources to help you improve on that particular change idea. So think of the change package as the broad menu of evidence-based options, and then I want to go through a few of the individual strategies highlighted in the change package. And one of those is using standardized hypertension treatment protocols for blood pressure control. These are also known as care pathways, care algorithms, whatever you want to call them. They're standardized approaches to care. using a standardized treatment protocol sends a strong signal to your clinical staff that hypertension control is a priority. They also help to reduce clinical variability where the science is clear. So we're not trying to promote cookbook medicine, but in many cases, science is crystal clear about what should or should not be done. They also better enable all members of the healthcare team to titrate medications. So they really can support the concept of team-based care and help us overcome clinical inertia if that exists. On the Million Hearts website, we showcase resources to support protocol implementation for hypertension control, but also cholesterol management and tobacco assessment and treatment as well. So you'll find examples from health systems that have effectively implemented treatment protocols, as well as implementation guidance and a customizable template for hypertension and tobacco use. So if you're interested in this arena, definitely check out the URL on this slide. There's lots of good tools there. Excuse me. So another strategy highlighted in the change package is self-measured blood pressure monitoring, or SMBP. This is also known as home blood pressure monitoring. There are several rigorous systematic reviews that have found strong evidence that SMBP plus additional clinical support helps reduce blood pressure and increase hypertension control in patients with uncontrolled hypertension. There's also a growing body of evidence for its use in confirming hypertension diagnosis, as was highlighted in the recent U.S. Preventative Services Task Force guidelines for hypertension screening. And so the real crux of SMBP plus additional clinical support is what I like to refer to as the patient-clinician feedback loop, where the patient is trained by clinical staff to use a home monitor that has been validated against the office monitor, and when the patient takes their blood pressure at home, they have a way to transmit those values, lifestyle habits, medication side effects, etc., back to their clinician, who can then interpret the patient-generated values and provide titration and or lifestyle modification advice based on the patient-generated data. On the Million Hearts website, we showcase a number of resources on SMBP that provide clinicians tools to implement SMBP with their patients, including a suggested protocol for home monitoring and how to start a blood pressure cuff loaner program. So I want to switch gears just a bit. I mentioned before this idea of finding potentially undiagnosed hypertensives. Well, as we've worked with health systems to gather best practices in hypertension control, some of them realized that they have a non-trivial number of patients with abnormal blood pressure readings who had not been officially diagnosed with hypertension. And so we've dubbed this particular phenomenon of potentially undiagnosed hypertensives as quote-unquote hiding in plain sight. Earlier, I talked a little bit about clinical quality measures, and just to circle back to that, Million Hearts and, as I said, a number of quality reporting initiatives like the Home Health Cardiovascular Data Registry are judging the quality of care to hypertensive patients using a clinical quality measure known as NQF-18 or other close measure analogs. So that's basically the percentage of adult patients who had a diagnosis of hypertension and whose blood pressure was adequately controlled during that measurement year. So in order for a patient to be included in this quality measure that assesses clinical performance, they must have a diagnosis of hypertension. So by default, clinicians are judged on how well they control high blood pressure among diagnosed hypertensives. So these measures overlook the potentially undiagnosed hypertensive population, and I want to show you why that could be really important. So let's look at what I like to call some Hillary math. If we take a practice or home health agency, for example, that has 100 adults with diagnosed hypertension, if 70 of those adults have their most recent blood pressure under 140/90, which is considered to be in the safe zone, then that practice has a 70% blood pressure control rate, which we should celebrate. But what if we take a closer look at the patient population, and what if the healthcare setting has 50 patients with multiple abnormal blood pressure readings, but who have not yet been given a diagnosis of hypertension? if we include all of those patients in our measure of blood pressure control in the denominator, it has the potential to have a real impact on blood pressure control rates. You can see we had 70% control before. With this added bolus of patients, we dropped down to 47% control. So that makes a big difference. Now, obviously, this is a worst-case scenario that I'm describing. It sort of assumes that all 50 of these patients who are, quote-unquote, hiding in plain sight definitely have hypertension, and we know that that may not be the case. But I will tell you, this phenomenon is real, and it can negatively impact a practice's blood pressure control rates. So it's definitely something that we need to pay attention to. And this magnitude of sort of, you know, 1/3 of patients who might have hypertension or who do have hypertension being potentially undiagnosed, that magnitude is not an over-exaggeration. That's actually what a number of large health systems have found in their own patient population. So back in 2014, we published a viewpoint in JAMA that summarizes what some large health systems have done to address this phenomenon. And as we did the research for the JAMA viewpoint, we tried to look for common themes, and 4 of them really came to the top. These included using data to determine whether or not a practice might actually have an undiagnosed hypertensive problem, then setting definitions for a patient with potentially undiagnosed hypertension. I call these clinical criteria. How do you know, how would you, define whether or not somebody might have hypertension? Then exploring electronic health record data to find patients who meet those clinical criteria that you have defined. And lastly, implementing a plan to confirm whether or not those patients actually have hypertension. And, right now we're talking about this data exploration process specifically for finding patients with potentially undiagnosed hypertension, but these same principles can be applied to diabetes, chronic kidney disease, abnormal cholesterol, tobacco users, asthmatics. You name the condition, there's likely some undiagnosed folks who could be found through EHR data exploration, as I've outlined it. So if you'd like to hear more about potentially undiagnosed hypertensives, the Maine Center for Disease Control and Prevention created a great video that explains the phenomenon. And actually, CDC created one too, but I like the Maine one much better. So I like to point people there. But we've also developed and gathered some additional supporting resources on the topic that, again, you can find on the URL at the bottom of this slide. So we've talked a lot about hypertension, but I thought I would take a few minutes to highlight some additional tools and resources related to sort of broader cardiovascular health. First, we've got what we call our Tobacco Treatment Action Guide. This provides information and resources for clinicians who are looking to more actively support tobacco cessation efforts of their patients. This includes information on the 5 A's brief intervention model and information on FDA-approved cessation medications. And as I mentioned before, there are tobacco cessation, tobacco assessment and treatment protocols on our website as well that sort of go hand in hand with this action guide. And let's see. As I said earlier, let's see here. Another new area for 1 Million Hearts is particle pollution. This is also referred to as particulate matter. This is made up of tiny particles or solids or liquids in the air, and usually the particles are so small you can't quite see them. So research shows that short and long-term exposure to particle pollution are both linked to an increased risk of heart attacks and other forms of heart disease, and can be particularly dangerous for people with known heart disease. So we have a pretty newly developed webpage devoted to particle pollution that showcases tools and resources for clinicians and others. And one of the tools that we are actively working to draw attention to, particularly for those people with known heart disease, is the Air Quality Index. And I'm sure you have heard of the Air Quality Index. Most people have. It's also called the AQI, and basically it reports daily air quality. The higher the AQI value, the greater the level of air pollution and the greater the health concern. And you, like I said, you've likely heard or seen references to the AQI on your local news or NPR, but often it's only really highlighted for people with like asthma and not for people with cardiovascular disease. So it also may not be obvious what people with those conditions should do when the AQI is high. So for people with known heart disease, when air pollution is high or the AQI is high, they can reduce the amount of particle pollution they inhale by doing things like delaying outdoor activity until the air is cleaner, reducing activity level. So for example, going for a walk if they had planned to go for a jog. They can also move their exercise indoors or avoid exercising near busy roads. And I think your patient population, some of that may be a little bit less applicable. I don't know how much they're getting out of the house and actually exercising, but even they can do things like closing their windows when the AQI is very high, not burning candles, things like that. So this is definitely a topic that I think you all play a role in helping to raise awareness among people with known heart disease. I wanted to put some specific resources down for folks with known heart disease, ways that they can check the air quality index. There is airnow.gov that you can put in your zip code and it shows you the air quality index for your area. There are tons of smartphone apps that can give you alerts. Obviously, as I said, radio, TV, or internet news, and there are email alerts that you can sign up for at enviroflash.info. So lots of good stuff there, and that's sort of a new topic for Million Hearts, but frankly one that I find really exciting. So the ultimate goal of Million Hearts, as I said earlier, is to prevent acute cardiovascular events and deaths, and cardiac rehabilitation is an evidence-based secondary prevention program that can really meaningfully contribute to this goal. So cardiac rehab provides participants with nutritional, psychosocial, and physical activity counseling. There's aggressive risk factor modification with baseline and follow-up assessments, as well as supervised exercise training. So participation in cardiac rehab can significantly reduce deaths and rehospitalizations for people who have had a heart attack and or revascularization or other eligible cardiac event. And there are many other well-documented benefits, things like improved quality of life and decreased depression as well. So despite all of these well-documented benefits of cardiac rehab, only about 20% of eligible patients are referred to cardiac rehab, and only half of those actually participate. So Million Hearts is trying to increase the percent of eligible patients who participate in cardiac rehab to about 70%. To reach that target, over 40 organizations have come together to create what's called the Million Hearts Cardiac Rehab Collaborative, and Cindy has participated on that, which is great. Some of those participants several months ago co-authored a Million Hearts Cardiac Rehab Roadmap, which outlines evidence-based strategies for increasing cardiac rehab referral, enrollment, and participation. And my team, the Million Hearts Science team at CDC, is currently using that roadmap as a basis for a cardiac rehab change package. And we will also have a landing page on the Million Hearts website in the near future for cardiac rehab resources. One of the hot topics for discussion in the cardiac rehab world is home-based or hybrid models of cardiac rehab, and there's sort of an ongoing lively debate about the topic, and I think all of you have a definite role to play in helping to sort out this issue, and I would love to hear any thoughts you have on the topic when we open it up for questions. As I said earlier, Million Hearts has a new focus on reducing physical inactivity by 20%. So we recently launched a web page dedicated to physical activity and cardiovascular disease. There you can find information about evidence-based behavioral counseling programs like the National Diabetes Prevention Program, as well as community-based activity programs like Walk with a Doc and Girl Trek. There's also good evidence, including a very recent systematic review from the Community Preventative Services Task Force, that shows changes to our built environment can improve health outcomes. And we've gathered some resources that support built environment efforts on this webpage as well, if that's of interest to you. A common thread that runs through most of the Million Hearts clinical resources is health information technology, and we have gathered a suite of resources related to various aspects of health IT. These include guidance on EHR optimization, particularly on the ABCs, selecting population health management software solutions for quality improvement. There's resources on bidirectional e-referral to evidence-based programs like smoking quit lines, as well as the utility of patient portals and how to use them for improved patient engagement. So I'm kind of a health IT junkie myself, maybe some of you are. I highly encourage you to check out those resources. So that's sort of it for the resources, but if you are interested in getting bi-monthly updates on Million Hearts tools, resources, and science, you can subscribe to our e-newsletter from our homepage. As I've illustrated on this slide, it's a little hard to describe how to get there, but you just push the purple button. And with that, I will thank you for your time, and I would be happy to take any questions you have or hear your thoughts on home-based cardiac rehab, etc. Thank you.
Thanks, Hillary. We appreciate that. That was a lot of information. I hope everybody was taking notes as fast as I was. I want to just encourage everyone to use the Q&A feature on the right side of your screen, and go ahead and also make sure your lines are muted, because we will be unmuting the lines very shortly to take questions and discussion on home-based cardiac rehab. That is an area that we are interested in hearing, and of course any questions you wish to verbally ask. So giving you about a 5-second warning, we're getting ready to unmute the lines, but you can continue to use the Q&A feature on the right side of your screen. So Misty B, if you don't mind going ahead and unmuting all the lines, and let's see if there's questions that you have that you'd like to verbally ask, or if you have any comments on anything that was shared on today's webinar.
I'm struggling a little bit to unmute the lines here. Hang on just a second.
That's fine. And Hillary, I'd like to thank you again for bringing in the EPA about the AQI, because the air quality index was something that surprised me with the new Million Hearts. We're in phase 2 right now. And I think as home healthers, as we all are, we consider what our patients are doing in the home, and the air quality, especially for those in altitude, it's not just an urban issue with exhaust pollution, but also those who are in higher elevation. The air is already thin, whether it's the Rockies or other mountain ranges. The air is thin. Slightest amount of air quality index decrease is going to decrease our cardiac patients' oxygenation, and that impacts everything that we do in the home. And many of our patients are using windows as airflow. So thanks for bringing that in today. I appreciate it. We want to keep that on the forefront of all of the care that we provide.
Absolutely, and Cindy, I think you'll find some great resources on that webpage that we have developed, and I'll let you all know we are working to develop some additional resources, one for clinicians to really give like a granular, here's what we want you to tell your patients with known heart disease about the air quality index and air pollution in general, and then also a handout that will be specifically for patients with known heart disease.
Thank you for that. Again, everyone, we'd like to remind you to make sure the lines are muted if you're not wanting to ask a question, but we will go ahead and pause here for a second for anyone that would like to ask a question verbally, and then we'll get to the questions in the queue on the Q&A feature. Okay, we'll go ahead and go with the Q&A feature. And these are in no particular order, Hillary, so here we go. What do you see as the role of the state health departments in Million Hearts 2022?
Oh my goodness, huge, huge role. And one of the things that in the introduction that Cindy gave before the presentation, she mentioned that I have experience in state government in cardiovascular disease prevention. I actually worked for a state Department of Health for 5 years as an epidemiologist and program evaluator, specifically in cardiovascular disease prevention. So I think there's a huge role. But I'll tell you, not all roles are equal. There are some states who are working actively, some state departments of health who are working actively with clinical partners, and that's where I see sort of the most opportunity. Doing things like trying to get widespread implementation of self-measured blood pressure monitoring, and there's a whole host of roles that states can play in that continuum. Excuse me. Doing things like encouraging the use of standardized treatment approaches. Some state departments of health have convened hypertension control quality improvement collaboratives where they're sharing tools and resources and trying to work with clinical providers to improve on hypertension or the ABCs in general. But also there's this whole public policy side that I sort of glossed over in the beginning, and there's huge things that state departments, state and local departments of health can do. And so for sodium, those food procurement policies, you know, states as an employer or states as entities that give out grants have a lot of leverage in saying whether or not, you know, meetings can be held with low sodium foods, or they can set up things like vending machine policies that only include healthier food options. So lots of room and lots of work in that space. When it comes to air quality, there's a whole bunch of things, a whole bunch of policy levers that can be pulled. Things like idling laws for taxis and delivery vehicles. If those idling laws exist, there's we have to make sure that they're actually being policed and being carried out appropriately. And then in tobacco, there's a huge role for state departments of health, and I could get into that for a half an hour about their role, but comprehensive tobacco control programs exist in most states, and so there's a huge role for state departments of health.
That sounds wonderful, and thank you for sharing that. I think you gave a lot of good ideas of thinking outside of the box. The next question is the protocol of algorithm sounds like it could be applied to chronic illnesses. Do you have do you have a protocol for patients with 2 or more chronic illnesses such as diabetes and hypertension?
So great question. We don't have that specific protocol developed, but if you look at the protocol examples that we've highlighted on the website, what you'll see is sort of general, you know, hypertension control. Does the patient have a blood pressure of this value or this value? And then there are considerations for patients with diabetes, consider these medications, or African American and Black patients, consider these medications. And we're also working with the National Kidney Foundation to develop some tools in the chronic kidney disease space. So all of that is sort of highlighted in these protocols, and I think different health systems have addressed that in different ways. But that's absolutely something that you need to consider, that, you know, people with hypertension generally don't just have hypertension, they have these other conditions as well, and sometimes that dictates that different medications need to be used, or you know, different titration levels should be in place, or follow-up should be different, follow-up time should be different. So I think it's there, it's just not posed as here is a treatment protocol for a patient with multiple chronic conditions.
And just in case, do you happen to know the status of patients obtaining diabetic test strips? I know that's not your forte, but I wanted to the question was asked, and I wanted to see if you knew anything.
You know, I don't specifically. If somebody wanted to shoot me an email, I'm happy to send that email to my colleagues in the Division for Diabetes Translation here at CDC. They might have an answer to that for you.
That's fantastic. And if you don't have Hillary's email, even though it's on the screen right now, but if you're in your car not able to get it, if you have those questions, you can contact us at hhqi@qualityinsights.org, and we'll be glad to forward that on to Hillary. The next question is asking about cardiac rehab. Could you elaborate on home-based cardiac rehab and what that entails?
Well, you know, I'll tell you, this is not my area of expertise. I'm really learning more and more about this, and I think I'm learning more about it as the body of evidence is growing. So I don't have a great answer to that question, but if I can find some papers that are really informative, I'm happy to forward those on if that would be helpful.
I'll speak for that person and say, yes, that would be very helpful. Thank you. Send it on to us, and we'll be glad to share it, because that is an area that we're looking into as well. That for Nancy Schroeder, who asked the question, and Kristen is asking about the cardiac rehab. When is it going to be released? Do you know when the cardiac rehab module is going to be released on Million Hearts by chance?
The web page or the change package?
Both.
So the web page, I would like to say, I would optimistically like to say both by the end of the calendar year. I don't know if you know this, but CDC has a very rigorous clearance process for any materials that go out, and so we're finishing up those materials, and then we have to put them into clearance. So unfortunately, that can take 2 months if we don't stay on top of it. It can take several months to get documents through clearance. So I'm hopeful sort of the end of this calendar year or early next year.
On behalf of the people who use the CDC resources, though, we really appreciate that clearance process, because the CDC website and the resources that are provided, we know have gone through that rigorous release process. So it makes it, it's a very dependable site. Sorry you have to go through it. We have something similar on the CMS side, but it's
sure,
it's appreciated.
Yeah, and I don't mind it. It just adds time to any project. That's all. But it is a good thing.
Yeah. All right, I'll tell you what, guys, we're going to go ahead and move on. We're going to come back to questions as time permits in just a few minutes, so continue submitting your questions to the Q&A feature. And now we'll turn it over to Misty Kevich for information about what's going on.
Wonderful. Well, we do have a resource we wanted to share we thought was very timely. The CDC Vitalsigns this month came out, or sorry, yeah, it is still September. I'm thinking it's October already. It was on preventing stroke deaths, progress stalled. And this really focuses on the point that Hillary talked about earlier about leveling off of some of the cardiovascular vascular leveling and reversal for some of those subpopulations and beginning to elevate. So the edition of the Vitalsigns goes into details, great graphs. There's a great infograph there, and a real short 1-minute video I thought was excellent to share with you as well. If you downloaded the handouts, all of those links will be available for you to click on. Now, the next several slides are just about this free continuing education for nursing. So there is 1.25 hours of CEs available. If you're listening to this live, you've already done that piece of this, but anyone can do this also if you're listening to the recording. You do have to register for the corresponding course in the university, and I'm going to show you that on the next couple slides. Do the evaluation and download and print your certificate. It is a piece of cake. Contact us if you have any questions. So you would go to our HHQI University site, and you will then go ahead and log in. Now, this is a little different, and that's why we have the red on this slide, than the HHQI general page. And the general page is where you go to get, like, the BPIPs and the education pieces. Sorry. But the HHQI University site, which is hhqiuniversity.org, that will be where you take your coursework. And if you can't remember if you've created a registration before, shoot us an email. We'll look it up for you. The reason we say that and stress this is that we really only want you to have one account. That way all of your courses, all your certificates are kept in that one registration, and we'd be happy to look that up for you. And let me get this to move to the next slide. There we go. And then you just go to the Cardiovascular Health Course Catalog, and then you will find a little apple to enroll, and then you go to My Accounts. And I'm showing on this slide the little books. They're now little green Go buttons. They just changed this end of the last week. So they're little green Go buttons, and you just follow the directions. It's really easy. All you have to do is really take the evaluation. When you're done, you exit out. You'll go to My Account, and your certificates are going to be listed on the left, and you can print those. If you're doing this from a mobile device, you now can also print those as well. You just have to change it to desktop view, and that also changed as of last week as well. Sorry, and I just want to make sure I didn't skip a slide. I was a little click happy there, but I think we are good, and I'll turn it back to you, Cindy.
Thanks, Misty, and I know everybody is working on getting to those CEs. We'll go ahead and, Hillary, if you're okay, it looks like there was a question. It looks like you've already addressed it, so thank you for that. Would you mind if we elaborate it verbally for those who might not have access? I'm not sure how this works in the recording.
Yeah, sure, I'm happy to, and I was just doing it in case we ran out of time, and of course I messed up my answer anyway because I hit entered too early. Anyway, the question was, yeah, the question was, is there any guidance or relationship between the air quality index and wood-burning stoves, et cetera, as winter comes? And so the short answer is yes, definitely. When you look, there are monitors throughout the United States that measure particulate matter, specifically those small particles I mentioned, PM 2.5, across the country. And what I was shocked about when I looked at maps of where there's poor air quality, Alaska was one of the states that came up as having some issues. And as I talked more to my colleagues at EPA and at the CDC National Center for Environmental Health, it became clear that that's due to wood-burning stoves. So in states like Alaska and in New England and other places in the country where in the winter wood-burning stoves are a source of heat, the air quality can be very bad. And so EPA has an initiative called BurnWise, and if you sort of Google that, you'll come to their resources, where they've worked to make policy changes to replace really old stoves. So the newer wood-burning stoves are more efficient, and they, I guess, sort of capture the small particles better and screen them out of the air. So they're doing a lot with, like, state departments of health to work on using certified stoves, giving tax credits and deductions for families that replace their old stoves with newer stoves, and using things like rebates and fuel credits to do similar things. So there absolutely is a relationship there, and again, that EPA BurnWise site has a ton of great resources if that's of interest to you.
That's excellent information, because as we're going in as home health clinicians, going into the homes, we're able to see that those wood-burning stoves are there. And even though we talk about the wood burning and the flame as a hazard with oxygen use and such, but this brings out a whole other, this is a whole other can of worms, and knowing those resources to go to, because those incentives, many of our patients cannot afford anything of that type, so it's good to know that those are available. So thanks for cutting our workload down and having to sort through and figure out how to help them, incentivize them to change the stoves out.
Sure, and,
okay,
and you know, this is also, oh, sorry, Cindy, I'll just say, this is also really pertinent to the wildfire issue that we're having across the country as well. That those wildfires produce lots of small particles, and we see sort of increases in hospitalizations for things like heart attacks when wildfires are burning. So that's also an issue.
That's a huge issue, depending on what part of the country you're in, so thanks again for that. Well, guys, we're almost at the top of the hour, so we'll go ahead and close this out. I want to remind you, if you continue to have other questions or questions that did not get addressed, or if you have questions that come to you, or as you're sharing this information with both your peers and your clinicians, feel free to contact us at hhqi@qualityinsights.org. We'll be happy to either answer your question or get your question to Hillary, our guest expert today. And Hillary, we'd like to thank you very much for taking the time out of your schedule. I would like to mention, everyone, the next Cardio Land, this is going to be a unique event in the sense that it is going to be the second Thursday of December. This is probably the first time, I want to say it's the first time ever that we have altered a third Thursday event, but due to the holiday schedule, we are going to have December 14th as our next Cardio Land, and this will feature home health agencies sharing really their cardiovascular experiences, both successes and challenges that they faced as they were integrating different cardiovascular changes into the care they provide. So we hope that you'll all be able to join us for that. And with that, we'll conclude today's webinar and say thank you for joining. Have a good day, everyone.